Welcome back to the Talking Ketamine podcast. This is episode 48, Ketamine and Diabetes, the Metabolic Tightrope.
Great to be here. Today we are looking at a huge group of people who are often left out of the conversation, diabetics. We have a new 2026 paper that asks a critical question. Ketamine might fix the pain and the mood, but is it safe for your blood sugar?
And that really is the critical question, isn't it? Because for anyone living with diabetes, these aren't just separate issues you tackle one by one.
Not at all.
We hear about treating metabolic disorders or pain or depression, but the sources you sent over, they paint a picture where these things are. Well, they're completely tangled together.
They absolutely are. The literature sometimes calls it multimorbidity, but I think a better term is syndemic.
Syndemic.
Yeah. We're talking about a group where, up to 30% of people also have depression. That's almost double the general population. So you're fighting a chronic illness, chronic pain, and a serious mood disorder all at the same time.
So what does that term syndemic, what does that actually mean for the doctor prescribing the treatment? What's the real danger there?
It creates this vicious feedback loop. The pain feels worse because your mood is low, and your mood gets worse because you're in constant pain.
Right.
And the depression itself, this is the crucial part, it just sabotages your ability to manage the diabetes.
It's hard enough already.
It's incredibly hard. Constantly checking your glucose, managing what you eat. I mean, when you're deeply depressed, those tasks can feel completely impossible. And that's when clinical outcomes just plummet.
And the research points out this isn't just, bad luck. There's a real biological reason these three things are happening together.
Exactly. The core of it is the metabolic chaos from prolonged high blood sugar, hyperglycemia. That drives this low-grade, constant inflammation throughout the body.
Right.
And that inflammation plus oxidative stress creates these things called Advanced Glycation End-products. You could just call them AGs.
AGs. So that's literally when sugar and protein get stuck together and cause damage.
That's a perfect way to put it. They're like little chemical injuries. And those AGEs are what damage the nerves, causing that burning diabetic neuropathy pain and that same inflammation. It fuels both the pain signals and the depressive symptoms. It's all one big biological mess.
So if you accept that you're fighting this triple threat, then a treatment like ketamine, which is a fast-acting antidepressant and a painkiller, it suddenly sounds like it's made for this exact problem.
The potential is just incredible. It's the ultimate two birds, one stone idea, really.
Right.
Its main power comes from how it works on the NMDA receptor. By interrupting that specific communication pathway in the brain, you're dialing down the main circuit for both pain and depression.
And on the mood side, you get that famous rapid effect.
You get that cascade, boosting things like BDNF, and you see symptom relief in hours or days, not weeks or months. For someone whose depression is making it impossible to manage their insulin, that speed is everything.
You're basically giving them back the ability to take care of themselves.
You're giving them their agency back. But then there's the pain side of it. That horrible, relentless burning nerve pain, diabetic neuropathy.
So how does ketamine help there? What's it actually doing to the nerve pain?
Well, think of the nervous system as being chronically wound up, like an alarm that's stuck in the on position.
The stuck alarm analogy.
Exactly. The pain pathways are just firing constantly, even when they shouldn't be. Ketamine's action on the NMDA receptor is like hitting the reset button on that stuck, malfunctioning alarm.
So you're not just numbing it like an opioid would. You're actually fixing the processing error.
It's a completely different approach. It's non-opioid. It's targeting the root cause of the nerve pain, and it's treating the depression at the same time. On paper, it's a home run. But the body, the complex diabetic body, has to be able to handle it. And that is where we get on the metabolic tightrope.
Which brings us right back to the central question, blood sugar. What does the research actually say ketamine does to a person's glucose levels?
And this is where it gets really complicated. The effects are all over the place. We have reports of hyperglycemia, big sugar spike, and weirdly, we also see reports of hypoglycemia, a dangerous drop.
Okay, let's start with the spike. That seems a little more intuitive. Why would a brain drug make your liver dump sugar?
It's that classic fight-or-flight response. Ketamine can temporarily kick the sympathetic nervous system into high gear.
Right, the stress system.
The stress system. So your body gets flooded with hormones like epinephrine, and those hormones scream at the liver to release its emergency fuel reserves. So you get this rapid but temporary spike in blood sugar.
And for a diabetic, any spike can be a big deal.
It's a very big deal. It means you have to be watching their glucose like a hawk during the infusion.
Okay, so that's the spike. But the drop, That one's harder to wrap my head around. Hypoglycemia, where did we see that happening?
The most compelling reports are from case studies with type 1 diabetic patients, T1DM. They were getting IV ketamine for their treatment-resistant depression.
And they saw their sugar drop.
They saw recurrent episodes of hypoglycemia. So, repeated, dangerous drops in blood sugar, sometimes during the session, sometimes hours after.
I mean, type 1 patients are on these incredibly precise insulin plans. What's knocking that so far off balance?
It seems to be a really complex mix of things. The drug might be messing with their insulin dynamics or their body's normal response to stress. For a body that's already so sensitive to insulin, ketamine might just tip the scales, and the body's normal safety nets that prevent low blood sugar just don't work right.
That sounds incredibly risky. If you have to bring in an endocrinologist and do constant glucose checks, does that risk maybe outweigh the benefit?
That's the million-dollar question. The research doesn't say don't do it. It says be extremely careful and work as a team. This is not a set-it-and-forget-it treatment for this group.
Yeah.
It means you absolutely must do frequent glucose checks before, during, and for a couple of hours after.
Because of those delayed drops.
Because of the delayed drops. You have to treat the whole complex patient, not just one symptom.
Okay, that makes sense for the blood sugar tightrope. But let's say we manage that perfectly. The drug still has to get processed and cleared by the body, and a diabetic's body handles everything differently, right?
Right. And that brings us to the next problem. The chemical traffic jam in the liver.
The liver.
Think of the liver as the body's main filter. Ketamine gets broken down there by a system of enzymes. You'll hear them called CYP450 enzymes. They turn ketamine into its metabolites, like norketamine.
So they're the little workers that clean up the drug.
They are. Now, here's the issue. In type 2 diabetes especially, you often have chronic inflammation and what's called non-alcoholic fatty liver disease. Basically, the liver is already sick and stressed.
Okay.
And that pathology, that sickness, can actually slow down those enzyme workers.
So the filter is clogged.
The filter is clogged, or at least it's very, very slow. And if the medicine isn't cleared efficiently, it hangs around in your system for much longer.
Which means a normal dose for a healthy person could be way too strong for a person with diabetes.
It's exactly way too strong, and the effects could last much longer. This increases the risk for all the side effects. More confusion, more dissociation, maybe even toxicity. It just makes the whole experience much more unpredictable.
And I imagine it gets even more complicated when you add in all the other medications these patients are usually on.
Oh, absolutely. That's the traffic jam. A lot of common drugs can either block or speed up those liver enzymes, which can send ketamine levels soaring into the danger zone or make the dose completely useless.
Other drugs can interfere.
And here's the really tricky part. Even their main diabetes drug might cause a problem. Preclinical studies suggested that metformin, the #1 drug for diabetes, might actually weaken ketamine's long-term antidepressant effects.
Wait, what? So the very drug they need to manage their diabetes could be fighting against the ketamine treatment?
It raises that very serious question. If the antidepressant benefit is blunted, is it even worth walking that high-risk metabolic tightrope we just talked about? So with all this variability, blood sugar, liver function, drug interactions, the idea of a standard one-size-fits-all dose is...
It's off the table. It's just not safe.
Which is why the research is calling for a move away from guessing and toward what they call smart math.
I love that term, yes. The solution is what's called model-informed precision dosing. It's a huge shift. Instead of just picking a dose, we'd use complex computer models that take a specific patient's data and calculate the perfect dose for them.
So you're talking about using a patient's entire metabolic profile to calculate one dose of one drug.
That's the future. We retire the average patient and start treating the individual in front of us. The research even lays out what data we need to be plugging into that math.
So what are those key factors? What do you need to know?
First, you absolutely need to know their renal function, their kidney health, because the metabolites are cleared by the kidneys and diabetes often damages them.
Right, so if the kidneys are slow, this stuff backs up even more. What's next?
Next is hepatic function. How healthy is that liver filter? We look at liver enzymes, inflammation markers. We need a clear picture of how much stress it's under.
Okay, kidneys, liver.
Third is their glycemic control history. How long have they had diabetes? What type is it? Is their HbA1c high or low? A well-controlled patient is a totally different ballgame from a poorly controlled one.
And I think there was a fourth one, genetics.
Yes, pharmacogenomics. Basically, your genes can determine if you are a naturally fast or slow metabolizer of certain drugs. That's a huge piece of the puzzle that we've been ignoring for too long.
This really is the definition of personalized medicine, isn't it?
It is, and the monitoring has to be personalized too. It's not just about blood sugar. We have to watch their heart rate and blood pressure closely because so many diabetics have underlying heart conditions.
You also mentioned urologic health, which seems very specific. Why the focus on the bladder?
Well, there's a known, though rare, risk with ketamine of causing a painful condition called ulcerative cystitis. It damages the bladder lining. And since people with diabetes are already vulnerable to kidney and bladder issues, you're stacking one risk on top of another. It just means you have to be extra vigilant with long-term monitoring.
Okay, let's pull all this together. We've talked about huge risks, but also this incredible potential. If we can nail this precision dosing, what's the ultimate prize here for the patient?
The ultimate prize actually brings us back to where we started, inflammation.
Right.
We know ketamine has powerful anti-inflammatory effects. It can suppress those nasty cytokines that drive so much of the disease. So the hope is that it might be doing more than just putting a Band-Aid on the pain and the depression.
You mean it could actually affect the diabetes itself?
That's the big provocative question. Could ketamine actually be disease-modifying? Could its anti-inflammatory action help heal some of the underlying metabolic and vascular damage from diabetes? We don't know yet, but it's a profound possibility.
So the takeaway here is clear. For the millions managing the trifecta of diabetes, pain, and depression, ketamine offers a new door. But it's not a door you walk through blindly.
Precisely. It requires respect for the liver, respect for the blood sugar, and a move toward precision medicine. We can't just treat the brain and ignore the body.
Treat the whole patient, that's the goal.
Thanks for listening to the Talking Ketamine podcast. We'll catch you on the next one.